So good evening, everyone, and welcome to this masterclass on lung oscillometry. So Indian Chest Society has been breaking barriers and breaking records, and you have been through many different webinars. This is a wonderful webinar, which I'm sure is going to help me as well as all the wonderful doctors who have logged in, because we have got wonderful panelists and speakers with us. And this initiative is by Indian Chess Society, and I should absolutely thank right at the beginning Dr. Sandeep Salvi sir, President ICS, Dr. Rajadhar, the Secretary ICS, and Dr. Amita, who has been the chair of TEI, the ICS, and has been actively getting us all together. So thank you, wonderful, all of you, for initiating this, and of course, inviting me to be a part of this, and Lupin for the educational support, for the support of going through the technical work behind the force which goes on for this webinar. So with that, we are going to be immediately starting off, because there are a lot of people who have already logged in, and what I have got the information, it's crossed already the 1,000 number. So lung oscillometry, as we all know, is not anymore the new kid on the block. It's growing up in stature, growing up in height, and growing up in maturity. Spirometry has been with us for a long time, and oscillometry is gradually making inroads. But there are many issues, many doubts, many apprehensions related to this particular topic. And we have got experts, international experts, as well as our own experts, who will guide us through these intricacies of interpreting, of applying this knowledge of oscillometry to clinical practice. So with that, I would like to introduce our first speaker. He's a fantastic orator, fantastic academician. You can see his resume right now. Dr. Leonard, Associate Professor at the Meekens Christie Labs at the McGill University and the Director of Clinical Sciences at Thoracis. Internationally recognized in the pathogenesis of lung diseases. I will not read everything, but the most important highlights of extensive publications in peer-reviewed journals for his research, and of course a PhD in clinical experiment physiology from Sweden. He is a mentor to medical students as well as postgraduates and fellows. He is a member of the American Physiological Society and American Thoracic Society, and has served on the Conference Planning Committee for the Respiratory Structure and Function Assembly. And his present and current research interests are focused on understanding how oscillation mechanics, a very important subject, can be used in the diagnosis of lung diseases as well as monitoring disease progression and effects of intervention. So I'm really happy, and it's our pleasure, Dr. Leonard, that you are going to be a part of this webinar, which is going to help us. We are waiting for your talk to gain more knowledge from you. So welcome, Dr. Leonard, and please, you can proceed with your talk. Thank you.
Thank you so much. It's a great pleasure and honor to be invited to join you here. Let's see if screen sharing will start here. Yes, it does, right? Okay. Do you see a sailboat?
Yes, it's visible.
Good.
Yeah.
Good. That's what you should be seeing right now.
Is it yours, Leonard?
Yes. What?
Okay, go on.
Everything's fine. Okay, great. Yeah, because I'm not really sure what I'm sharing. That's the problem. All right. So without further ado, let's move on. I was invited to talk about current and future applications of lung oscillometry. And this is kind of an interesting thing, because it really behooves on us as scientists to understand what is going to happen in the future, which of course we all know is impossible to predict. But I'm going to take a stab at it, and I find that very intriguing and interesting topic. So we'll see where we end up. First, some disclosures. I do have an employment with Thoracis, as just mentioned, own a very tiny sliver of shares there. And today I'm wearing my McGill hat, so this will be an academic presentation. So we all recognize the small airways. That's where the problems reside, and that is what eventually is going to kill you if you suffer from serious lung disease. And it was coined the silent zone many years ago because people knew that's where the problems are, but they couldn't really do much about it because there were no ways of really measuring what's happening there. So it's more sort of after the fact finding in autopsies and things like that this was the case. So we need to understand that this is really the big question for most of us. Of course, there are diseases affecting the large airways too, and there will be diseases affecting the very proximal parts of the lungs. But for the most part, if we can detect things while they are happening here, we might be able to take care of problems. So the traditional way of looking at oscillometry is really sort of more of a technological, almost engineering approach. You know, we deliver the test signal, there's minimal effort, it's quick, it's easy, and so on and so forth. I would say that it's also important to recognize that the parameters, for all the hesitations, I respect that. I would claim that the parameters are very intuitive and should be easy to understand with, you know, a minimal of effort. We do get small airways info, which is important as relates to the previous slide. What we are achieving in terms of data is model-based. That means that we have a relationship with structure and function of the lung, and that enables us to say something about where, or at least approximately where, the problems might reside, and also if they are resolved by treatment, for example. I would also claim that it's an excellent monitoring tool because it is very simple to use with relatively little training. And it will also aid with diagnosis. So these are the two things that people, you know, will come to see doctors for. They will want to have a diagnosis. Once they have that, they want to be monitored. So just a quick recap here. I'm not going to delve into this in any detail, but what we are doing with oscillometry is to essentially test how changes of airway flow and air volumes are impeded in the airways. It's really how do we move air in and out. But rather than having to rely upon the patient providing this the mechanics to do this, as we do with spirometry and to some extent also in a body box, we now have a machine doing it for us. So this machine, the oscillator, will deliver an oscillating signal that can take on some different shapes depending on the device you're using, but they sort of, the bottom line, they work very similarly. These frequencies are different frequencies, and that allows us to understand what is going on in the whole lung, or maybe more limited to the large airways and somewhere in between the smaller airways. All of this goes back to a wonderful publication, and this is, I would say, a must-read for anybody who has the slightest interest in oscillometry. Go and find this one from JAP 1956 by Arthur Otis. It's a wonderful paper. It has a lot of math in it, but he's really good at telling a story. So it's easy and very nice read, and you will have a really super understanding of oscillometry after reading this paper. So that's my recommendation. The outcome parameters we are playing around with are typically, I would say, R5. In children, it's typically R7. We do have a mid-frequency measurement point around 20 Hertz, 19-20 Hertz, depending on devices. The difference between the low frequency and the high frequency reflects on heterogeneity, homogeneity of the air movement in and out of the airways. So in a healthy lung, this should be homogeneous, in which case this is a straight line. In this example here, this would probably reflect some kind of disease. We also look at what is called the airspace derecumbent ventilation defects, AX. Now, AX is interesting because it's really an integration of the area over this reactance curve here, and it has the units of elastance. And elastance is nothing but lung stiffness. So an increase in this value will actually mean that the lung is now stiffer, and a stiff lung is not a healthy lung. So at the end of the day, we are usually looking at these two as the main outcomes in a lot of cases. Heterogeneity, that's not normal for a healthy adult. Having a stiff lung is definitely not normal. So these things are these parameters are the sort of, I would say, the most sensitive ones and the ones that I use the most. So now let's bring out the crystal ball here. And now, so this is my turn to go out on the thin ice here. And I just sat down and started thinking, okay, what is it about medical technology, which of course oscillometry is one part of? Well, it is a way of doing things that sort of detaches us from depending on the patient. So it will be a more objective way of assessing the health status of the body, no matter what you're measuring, be that blood pressure or lung function. But we are trying to offer the help to the patient and the healthcare providers by providing this device that can be much easier to use. The complexity in our case, the oscillometry, lies with the device. If you depend on the patient, well, then you have the complexity with the patient. So in spirometry, we leave all the complex things to the patient. You have to perform your utmost and you have to follow these instructions or whatnot. And we depend on that being the signal. Whereas if we use technology instead, we will actually take care of the complexities and the patient just need to sit there and breathe, which we are usually pretty good at. So we need to remove the fright of new technology and try to understand that the technology is actually helping us. And we need to eliminate the mystery of understanding physiology. I think this is a sort of modern problem in a way, because we have historically been teaching a lot of physiology in med school and in biology. I'm a biologist from the beginning. And so I studied a lot of physiology, but that has sort of skewed over to becoming more of immunology, cell biology, and so on and so forth. Nothing wrong. We need to have that too. But at the same time, physiology sort of fell by the wayside. Now we're realizing that what the patients really care about is not if their eosinophils are making a mess or if their IL-13 is gone array. They care about, oh, I have a hard time breathing. So we need to reintroduce the understanding of physiology. This has also to become a natural and integrated part of our healthcare. And if it's not, well, then doctors will not understand what the patient's problems are, and the patient will probably lack trust in the doctor. More care, I think, in the future will be delivered at home. I happened to listen to another webcast the other day, actually, where somebody elaborated on this and saying that, well, in most developed countries or countries with a good healthcare system, we don't want people in the hospitals because first of all, it's risky to be in hospital. You get sick in hospital, right? But people cost money once they step inside the doors of a hospital. It takes time away from other patients that might need the doctors and the healthcare providers' attention much more than somebody coming in with a whatever simple cough or whatever it is, or just have a new prescription. So I think more healthcare will be delivered in the home in the future, whether we like it or not. I'm not trying to take away your job, but I think this is in the crystal ball. Healthcare will thus be much more of an integrated part of our lives in the future. It is already there with these smart watches and apps we have on our phone, keeping track on how many steps we take per day or how far we run, the blood pressure, and so on and so forth. At the end of this, just teasing a bit to loop in here maybe, I think all this will also help clinical trials. It will make them more effective and more precise. And that's also a sort of another benefit of what's happening with the medical technology advancements. All right, so now we're going to go into the more specifics about oscillometry here. Why? Well, I already mentioned the small airways disease, of course. I think this will provide a very important piece of the puzzle in helping with a good diagnosis. Because if you have a good grip on what is working, not working, you can actually titrate the treatment much more to that particular patient's needs. Remember, we are in an era of more personalized medicine. Bronchodilator test might be a good way of determining asthma control, which I will touch upon in a moment. Hyperresponsiveness testing is something that in some parts of the world is used extensively, in other parts of the world not so common. My impression is that it's not so common in India as it might be in other countries. So this has more to do with culture than anything else, and traditions and such. We need high quality clinical studies, and those have to deliver objective measurements that are not influenced by whomever is doing the measurements or doing the tests. So for the industry, this is important, so they can tailor their clinical studies to their needs and not overdo them in terms of size, yet have high quality data coming out of them. Another thing I will touch upon is that we also need, at least to start with, try to separate obstructive from restrictive lung diseases. As it turns out, that can sometimes be somewhat difficult. So this is on the diagnosis side. Look here, monitoring. Well, the monitoring is really what you do most of the time. Diagnosing is something we typically do like once, and then we know that this patient has asthma, he has COPD, he has cystic fibrosis, whatever it is. Now comes the time to do monitoring. And monitoring, of course, should not be something that takes half a day. It should be something that you can do very quickly and easy, and not do the full workup once more. So I think that's where oscillometry would play a big role. Self-monitoring is something we're going to talk about briefly. Early warning, wouldn't that be wonderful? Because if you monitor with some sort of regularity, hopefully that will give you an early warning sign that something is going wrong and you need to change your treatment or whatever. Again, monitoring is important in high quality clinical studies, because rather than just doing a measurement before and after treatment, maybe do several measurements during the treatment to follow and see what's really happening. And that is going on as we speak, actually. And this is important to enable us to titrate treatment again. So you can see there's a lot of overlap between both diagnosing and monitoring. They do actually have things they share. All right, let's start here with assessing asthma control. So first of all, baseline lung function measurements are fine. And we can do that with spirometry, we can do it with oscillometry. That doesn't really matter, whatever is working. But now talking about oscillometry, if you do that only once, well, you're still left with the question, what's happening in between those half year, seeing the doctor. The problem with the lung, the problem for us as trying to understand what's going on, is that the lung has a lot of redundant capacity. It has so much extra capacity that it often, I've seen publications saying that somewhere between 50 and 60% of the lung has to be affected before the patient really starts complaining. We can adapt to a lot of bad changes in the lungs before we really start suffering. So that means that, well, now we have an organ that is highly, impeded by disease, and it might be too late to go back and cure that. So the trick is to challenge the system in one way or another. And, essentially there are two ways of doing this for lungs. Either you try a reversibility test, bronchodilator test, or the other way is to constrict the lung, doing a hyperresponsiveness test. So these are the three ways of doing it. Baseline reversibility and hyperresponsiveness test. So here we can look at a report that came out just 2 years ago from Denver. And they are interested in using oscillometry in the emergency room. The idea is to check the kids frequently during their stay in the emergency room and decide whether they should go home or if they need to be admitted to the floor. Again, the point is to keep people out of the hospital. If they don't need to be in the hospital, they should go home. In USA, this has also implication for parents because they need to take time off and they might be losing their job and whatnot if they have a sick kid. That's a tragic fact in the United States. What we can see here is that improved lung function here is actually that this value goes down. We're looking at Z scores here. So the kids come in, they have a high Z score. They are treated with whatever they're treated. This is, of course, individual in the ER, and they come down. And you can see here that the resistance came down to right around 0. So this was an improvement. And they did so within a couple of hours. Without oscillometry, they might have been sitting there maybe for half a day. And here we have the reactance. I believe this is reactance at 5 Hertz. Either way, the Z score also goes in a similar direction. And you can see that they're now approaching the lower limit of normal here. So this is improved lung function. I think it's worth to note that the variability is big when people are exacerbating. When they're under treatment, the variability will be reduced. So this speaks to this heterogeneity parameter R5-20 or R5-19 that we talked about before. Here's another interesting case. Patient home monitoring, again, an asthma case. This is a teenager in Australia. Let me guide you through this somewhat complex graph here. The purple bars here are when the patient took their drug. So they had smart inhalers registering when people actually took their drugs. You can see this kid was pretty good at taking his drugs, you know, early on here. Then he started dropping out of that habit. The red dots here are resistance at 5 Hertz. The blue are reactance at 5 Hertz. So you can see when the child is taking his drugs with at least some regularity, everything seems to be in control. He's right around where he should be. The normal values are indicated by the dotted lines here. However, when he or she started skimping on the drug, what happens? Well, you can see that there's a trend, of course, for the resistance to increase and reactance to decrease. However, what is really striking to me is that the variability goes up. There are days when he or she is perfectly normal, interspersed with days when things are pretty horrible. So going from a resistance of about 4 or so up to 10, that's noticeable for anybody. Eventually, things got so bad, it was called exacerbation. And eventually the doctor reinforced the need to have good adherence to taking your drugs, which should not be, you know, should not be needed to be told, but that's the way it is. I think it's also interesting to notice here that once you've been up here, it is actually pretty hard to come back to a perfectly normal state. You need to stick with your treatment in order to keep this going. So monitoring, which I think this is a good example of, in the home maybe, at least for some severe cases, could be really, really important in the future. Reversibility testing, why use that? Well, I think if you are reversible, that means that there's room for improvement. So this is reversibility on top of your regular treatment. It could indicate you had inadequate treatment. Maybe you got the totally wrong drug. Maybe you have some type of whatever disease that is not treated optimally. Could just be a simple dose adjustment. You need to increase your dose of steroids. I don't know. Could be just changing, adding some modality. Could be getting rid of the cat or the parrot or whatever people keep at home. Something that triggers your allergy. So all of these things are important to understand. Lack of reversibility could actually indicate a permanent or fixed obstruction, or maybe even COPD. So reversibility testing is revealing. some people could start with asthma, but for whatever reason, later on in life develop a COPD component. So it will help with the further sort of added diagnosis. So this is a paper from Australia again. Alice Cottee is the first author, and go along the similar lines using bronchodilators in order to understand how asthma is working. I think it's a very interesting paper because they show that using spirometry, you can pick up some subjects with a significant bronchodilator response. But if you use oscillometry, you can actually pick up many, many more. And their conclusion, this is quoted directly from the paper, is that using oscillometry poor asthma control, and the reactance parameters are much more sensitive, and this is a good complement to spirometry in the clinical management of asthma. And just to summarize the paper here in some text, only one subject had bronchodilation response based on FVC alone. Oscillometry identified almost twice as many as spirometry. Only 2 subjects were identified by spirometry and not oscillometry. So that gives you the idea how much better this was. And it's very clear that oscillometry can identify poor asthma control. So again, using this in a clinical trial is of course elegant, because if you try your new candidate in a clinical trial and you think, well, baseline shifted, but did it shift enough? Well, test with the bronchodilator to see if you can still improve. That might be a good idea. And I know that drug companies are doing this now. I have to say, talking in India as I do today is sort of preaching to the choir, because in India, I've noticed that the uptake of using bronchodilator testing is really, really good. And a lot of you guys have been in touch with me, or others in like Dr. Reis-Wanacker and so on. And we always see that people use bronchodilator testing, and it's very informative. So this all adds a nice piece to the puzzle, understanding what's going on. So now going into more of bronchodilator responses, here is an interesting case that I got from a friend back in Sweden, my old alma mater, by the way. Now, this is an old lady. She's 82 years old. She has Sjogren's syndrome, scoliosis. So there's a lot of comorbidities here adding to her old age. Her MD, her GP was worried that she had some asthma components or whatever, that she might, not only suffer from these things that were well known. So she was admitted here to the clinical of physiology, and they ran her through the standard battery of tests. As you can see here, pre-bronchodilator, she's definitely low on TLC and RV, and FSC is somewhat. Her spirometry is not the best. 68% here predicted in FEV1, for example. The interesting thing is that bronchodilator did absolutely nothing. Zilch. It didn't change a hair. It was just the same. And isn't that peculiar? Now, the thing they do at this hospital is that they have oscillometry and have used it for like 20 years. And they almost always do oscillometry, spirometry. In this case, they did that. And this is with the iOS device. So the layout of the graphs are somewhat different from what we usually see. But nonetheless, if you're up in the gray zone here or down in gray zone here, you can see the ideal line for reference data is the thin gray line here. So this indicates that this lady, she was definitely outside of the range of her normal. Maybe not that much, but definitely not fully healthy. And now they gave her the bronchodilator. Look here, resistance totally normalized. Reactance also fully normalized. And she is obviously very reversible. So this is not a fixed obstruction she's suffering from. Why it was not detected on spirometry, we can speculate. However, I would say with her age, I don't know anything about her mental status or anything, but even if she's fully aware of things, it might still be very difficult for somebody who's old with also some comorbidities to do a full high quality spirometry test. So this actually suggests that this is a reversible thing, and maybe she could be treated for it. Unfortunately, I don't have any follow-up on this lady, but fingers crossed she was receiving proper treatment. Now, the other thing I mentioned was that we can do a hyperresponsiveness test, and there are a number of ways of doing this. It's very time consuming. It has to be done by personnel that is trained in doing it proper. Patients just hate it because it's very, very exhausting. Here's another example, again, from the same clinic in Sweden. Again, a young woman, non-smoker. She was previously healthy, but now she had cold symptoms, and over 2-3 months after going through some sort of cold, no known allergy, her X-rays are normal, FEV1 is less than 70% predicted. She has short stature, and she was born prematurely. So there's that in her history. But she was not reversible on spirometry, which you can see here. The green line here is what should have been the reversibility, but she's not. They didn't test reversibility on oscillometry. At least I don't have access to that data. However, they did, and this is something I'm going to come to in a moment here. They did a hyperresponsiveness test with methacholine. So what you can see here is the response here in percent change from baseline. And here we have methacholine accumulated dose on the x-axis, and we can follow the oscillometry here, follow the red line here, and you can see that it crosses right around here. This is the 50% increase. This is what is traditionally used as the cutoff for oscillometry. You can see that in spirometry down here, the crossing of the standard is right around here. So and here, just for reference, is a normal value from normal people. So it appears to me that maybe oscillometry is more sensitive than spirometry. And wouldn't this be beautiful if we could do this with fewer doses, not having to do these forced exhalations and all the maneuvers, and maybe get this done relatively quickly and easy? I think that would be a beautiful thing if that would be possible. So let's see what the future brings us here. Here's another case. This is a 14-year-old girl, again with allergy history to pollen and furry animals. She had low volumes in spirometry, but again, no reversibility. As we can see here, the green line didn't budge. Again, what they do, they put her through the hyperresponsiveness test, and again, we can see here that 150, I didn't put in the line here, but it's crossing somewhere around here. Again, this appears to be at the lower dose than spirometry. So she was clearly hyper-responsive, again, indicating allergic asthma. So this is what I would like to come to with all this. And so this is according to me. Well, I'm allowed to speculate because that's what I'm invited to do here. So the patient comes in with a complaint, which at face value might sound like, all right, it sounds like an obstructive disease. What would we do? Well, so one workflow thing one could have is this. You do baseline oscillometry, sorry. If it's abnormal, well, then you do a reversibility test. If the reversibility is there, well, that increases the likelihood for putting asthma high on the differential diagnosis. If the reversibility is negative, i.e. no reversibility, well, then you do what they did in Malmo. You do an airway hyperresponsiveness test. If that comes out positive, well, that again puts you in the ballpark of asthma. If that is negative, well, that puts you in the ballpark of COPD or some other cause of obstruction. If the baseline oscillometry is normal, well, and the patient have all the complaints and the history speaks for, obstructiveness, well, do an AHR test. And if it's positive, again, you end up in the asthma corner. If the patient is not hyperresponsive, yet there are complaints that would commensurate with a true lung disease, well, it's something other, and that requires then further investigation. So this is one idea I had of how we could approach and use these things to our advantage to speed up the diagnosis. I just want to share this. This is something I did together with my friend Hammacher in Switzerland, in Bern. He has a big clinic there, and he sees a lot of asthmatics and COPD patients and other things too, by the way. We just extracted from some of his records a number of asthma patients and a number of COPD patients. They're all regular patients coming into the clinical follow-up. So it's not a clinical study that is well controlled, really. So it's really an excerpt of what you can find in his clinic. They all had clear diagnosis of asthma or clear diagnosis of COPD. That's the only thing we went for. He also has the routine of doing bronchodilator testing. And you can see the asthmatics, they dilated here. Resistance went down for R5, not so much for R20. AX also decreased. Look at the COPDers. Nothing happens. Almost nothing happens. So this sort of gives fuel to my hypothesis that one can use reversibility testing as one tool in order to separate out these. Now, I'm just a couple of slides away from my end here, and so I'll just point to the clinical studies that can be done with high quality. So this is an example from that was published a couple of years ago, where they used an extra fine formulation of BDP and fluticasone inhaler on asthma, and it's shown that R520 diminished by a lot, X5 changed positively, and AX as well. And this was commensurate with a FeNO change as well after 1 month of treatment. And it's all depicted in this nice graph here. I think this is the cool one that I picked up at ERS this year, where they have this combined TSLP, which is a signaling alarming molecule related to type 2 asthma, and IL-13, again, the same thing. They had a small study, 36 subjects, rapid improvement with single dose. It lasted for 57 days, and they concluded oscillometry resistance at heterogeneity and reactance area, the stiffness of lung, was consistent with improvement in small airway dysfunction. And of course, it wouldn't be me sitting at a room there if I didn't take a photo of the presentation. So we can look here at the dotted line here. This is the improvement R5-20. So heterogeneity went down significantly and stayed down for 57 days. And here we can look at the elastance, same thing, a good improvement. All right. The last thing I would like to highlight, how good are we at interpreting data? Could artificial intelligence do it better? Do we need anything beyond oscillometry in the future? Well, so this is again from ERS, and this was shared to me by Dr. TC from Toronto. They had a machine learning algorithm. They fed in the algorithm with a lot of reference data, taught the machine to identify normal, restrictive, obstructive, and a mixed obstructive restrictive disease. And all this was done by standard ATS-ERS guidelines. Then they submitted to a number of experts in oscillometry to look at oscillometry data only. And then I was actually one of the experts, so to say, here, and we were asked to grade the patients we saw in these 4 categories. I would say we were pretty good nailing down the normals, although not perfect, whereas AI nailed them 100%. We failed pretty miserably in separating restriction, obstruction, and forget about the mixed profile. We were really bad at that. Not that the AI was really good either, but the total difference between AI and the expert was still in favor of AI. And you have to remember, this is an abstract, it's a small sample, the first baby steps in this. I think this is actually future. We will probably have something like this coming out in the future where we have AI taking care of a lot of these things for us. So I think we need to move from the 𝐶𝐽 state of the art. It's actually not that we will be moved from the 𝐶𝐽 state of the art. This is nothing we can really do anything about. Technology will come whether we like it or not. Keeping the patient out of the hospital is something that all healthcare providers will love. Spirometry is probably failing patients and doctors. I think monitoring is key for good care and good research. This will end with AI taking over a lot of our job and help us guide us in the future. And this will also help with combining all of these things with home applications, and this will free up resources so we can spend our money on something else in the future. So thank you very much. Finally, a little plug for the book that's coming out anytime soon that I was happy to contribute to.
Okay, thank you, Dr. Leonard. As usual, it's always fantastic to hear to you, and you have told us what oscillometry can do now, and a peep into the future, that if you combine oscillometry with AI and other tools that are coming up, it would be really basically a wonderful tool to assess the obstructive disease and then also ILDs in also future. So thank you for the talk. Thank you for your lucid talk, which was illustrative. You also explained with the cases, and that really drove down the objective of your talk. Thank you. Thank you, Dr. Leonard. And it is also a pleasant opportunity to introduce my friend, Dr. Salil Bendre, who's actually a dynamic person. He's academically very good, and also he's an entertainer. As most of you who have seen him closely must have seen him as basically a magician. I think a very good singer. I have seen him in also a lot of mimicry. So academically and non-academically, he's just shining on the horizon. And I had the opportunity to take the exams with him in some of the couple of MD examination, and I really loved it, in fact, and I was looking forward to other opportunities. Salil. So Salil basically is a dynamic pulmonologist of Northern region, actually Mumbai, and he is ex-professor and head of pulmonary medicine in this 𝐾𝐽 Medical College. So I think, Salil, you are the boss today to moderate this house webinar, and over to you.
Thank you. Thank you.
Move on.
Thank you. Thank you. That was that made the mood a little lighter, but thank you for that introduction. So after that wonderful talk of Dr. Leonard, we will proceed to Dr. Sandeep Salvi. I actually don't need to introduce him because everyone, all the pulmonologists from India as well as abroad know him very well. But just to make matters more specific and more easy, he is, of course, going to be telling us the tricks and the trade, or how to manage, and few of the pointers for understanding oscillometry. He is the president of Indian Chest Society, member the board of directors Gold, member scientific committee GINA, chair of the chronic respiratory disease section Global Burden Disease India, a member of the steering committee on air pollution health, the Ministry of Health and Welfare, Government of India. Published so many papers, peer-reviewed journals, and the best, and I would say the most prestigious for all our countrymen, ranked #1 respiratory scientist in India by the Stanford University ranking 2023, the previous year, and number 52 in the world out of 60,472 global respiratory scientists. So he's the director presently of the Pulmocare Research Education, that is the Pure Foundation in Pune, and he's doing really wonderful work and helping us understand about not only oscillometry but respiratory physiology. His lectures are always a super hit. When he comes and gives talks, we are all eager to learn from him. So with that, I hand over the stage to Dr. Sarvi sir, and please he can proceed. Thank you so much.
Thank you. Thank you so much, Dr. Bendre, for those very kind words of welcome and introduction. It is a real pleasure to to be present for this very fascinating webinar on oscillometry. I bring to you greetings from the Indian Chess Society as the president, and I hope that you have been enjoying the webinar series that we have been conducting on obstructive airway diseases. I will be talking about the secrets of interpreting oscillometry, which I hope you will benefit immensely in your clinical practice. So let us start straight away. We are all well versed with spirometry, and the spirometry report gives you these two graphs, the flow volume loop and the volume time graph, and the 4 parameters, the 2 volumes, the 2 flows, and the ratio between the 2 volumes. The way we interpret spirometry is based on the percentage predicted values or the lower limit of normal, and more recently the Z scores have been used. And the reason why we need to use the percentage predicted is the spirometry values, they change significantly with age. And here you can see on the x-axis is the age in years. When you're born, you have about 1 liter of air in your lungs. As you grow old, up to the age of 20, there's a sharp and a sudden increase in your lung growth, reaches a peak at around 20, and then there's a slow and steady decline. So age has a huge impact on the spirometry indices. You can also see the differences in the ethnicity. The line on the top are those who are born in US or UK, and the line at the bottom are those who are born in Asia, like India. So the place where you are born decides how tall you're going to reach on your spirometry. The height also makes a significant impact on your spirometry predicted values, because as you grow tall, your thorax volume increases, and therefore your lung volumes also increase significantly. And in fact, these 5 parameters, they contribute to 70 to 90% of the variability, and therefore it is imperative whenever you're interpreting spirometry to have this data very properly fed, which will give you a predicted value or a reference value. And then using the reference value, you use the percentage predicted or the Z scores to make an interpretation. Now, with this background, do we need to do the same in oscillometry? The answer, very strangely and very interestingly, is no. So if you look at the resistance values, which is on the top, when you're born, your resistance values are high, and this is, I mean, R5 value at 5 Hertz. So where you got high resistance values at when you're born, as you grow older, the resistance values, they drop down until you reach the age of 15. And after the age of 15, it's almost a straight line. So age has no impact on the resistance values after adulthood. In children, yes. You need to either have this predicted equation, or you need to have cutoff values for individual age groups. The same thing also is seen in reactance values. So this is X5. You can see that the reactance is very negative when you're born, becomes less negative as you grow old, reaches the top at around 15 years, and it's a straight line after that. So during adulthood, you do not need actually predicted values to make an interpretation. You just need cutoff values. And I'm going to talk a little more about it in the subsequent slides. This is a very important paper that was published in December 2023 that derived the so-called predicted equation for resistance and reactance over here. So there are resistance and the reactance lines are here. The red line are females and the blue line are males. And very interestingly, they derived the so-called reference values from the age of 2.7 to 90 years. I don't think any other study has derived the predicted or the reference values at such a big age range. Now, what you see is exactly what I showed you in the previous slide. When you're born, you have very high resistance. It drops down until the age of around 17, 18. There is absolutely no difference between boys and girls. It's almost overlapped. And then after adulthood, after you reach adulthood, they more or less a straight line. But there is a gap between the males and the females. The females have a higher resistance value. The males have a lower resistance value. But you know what? Very interestingly, this gap is not because of gender differences. This gap is because females are shorter in height than males. So when you actually do the calculations for the difference between males and females from the age of 20 to the age of 19, the difference is only because of height. So gender has absolutely no impact on the resistance values. The same thing you see in the reactance values. The apparent difference that you see between females in the red and the males in blue is only attributed to height. So we very recently wrote a letter to the journal, the European Respiratory Journal Open Research, arguing for the fact that the only variable for oscillometry seems to be height. Gender is not important. In the adulthood, age is not important. So it's very fascinating that, tomorrow when you want to do oscillometry in a patient, the only parameter that you need to record is height. And the height is going to give you what should be the cutoff value. So this letter to the editor has just been accepted yesterday. And I think it's a very important concept that oscillometry is dependent only on height. No gender, no age. Using the Antlia device, which is an FOT that has been developed in India, we actually derived the so-called cutoff values. As I said, we don't need predicted values. We need only cutoff values. Just like how you need cutoff values for your blood pressure, for your blood sugar, for your blood cholesterol, you don't need a predicted equation, unlike spirometry. So the cutoff values that we derived for the FOT for the Indian population is mentioned over here. The unit is in centimeters water per liter per second. So the upper limit, let's call this as the upper limit of normal. For R5, it is 4 centimeters. For R20, it is 3 centimeters. R5 minus R20 should be less than 1 centimeter. X5 is -1. AX, which is the area of reactance, is 4 centimeters. And the resonant frequency is 12 hertz. So these are the cutoff values. But I must state that this is only for the adults, because for the children, you need to have cutoff values at different ages, or you need to calculate the height and then find out what should be the predicted value. So this is very fascinating because, it makes oscillometry a very simple test to perform. Only height is the variable that you need to measure. Now, the problem with oscillometry is that if you take different oscillometry devices, they will give you different values. And here is a study that was published about 3-4 years ago. Each line over here represents a different oscillometry device. So they don't give you the same values. At low test load, so low test load means which simulates healthy individuals, there is some difference that you get between the devices. This is for R5, resistance at 5 hertz. For reactance at 5 hertz, you can see that there is a much bigger difference, even in a normal healthy or a normal test load. So if you measure the X5 with this device, you should get this value. If you measure the X5 with this device, you will get this value. And look at there's a big difference between the two. When you increase the test load to simulate obstructive airway diseases, then the resistance differences between the devices become quite significant. And the same thing you see for reactance. Now, what does this mean for us in clinical practice? That different devices will give you different cutoff values. And therefore, if you have to make an interpretation, you have to derive the cutoff values for each device separately. If you do a test one day on this device and you do the test on the other day in another device, you cannot compare that because they give you different values. Up and until all these devices get harmonized so that all of them actually give you the same value, until that point of time, we will have to live with these differences between the devices. Now, for children, as I said, when you're 3 years old, the resistance is very high. It reduces as you grow old. So these are these sort of values that I have obtained from a publication. 3 years, it's 14. 5 years, it's 10. 10 years, it's 7. And for 15 years, it's 4. And then after 4, in the adult population, it remains a flat line. The same thing happens with reactance in children. So in a 3-year-old child, the normal X5 value is -5. In a 5-year-old, it's -3. 10-year-old, it's -2. 15-year-old, it's -1, and then it's a flat line after that. Resonant frequency in children is very high, up to 30 hertz. When as you age, the resonant frequency drops down, and in the adulthood, it's about 8 to 12. So the only point I wanted to make was in children, you need to have cutoff values for different ages or for different heights. But for adults, it is one single parameter. The oscillogram, like the spirogram, is this simple two-line graph that you get. On the y-axis is the units for resistance, either be resistance or reactance. On the x-axis is the frequency that at which the values have been measured. So you always start with the lowest frequency, which is 5 hertz. You go up to 20 hertz, and most of the other devices, they give you values up to 35. But for the sake of simplicity, I'm going to use only 5 to 20 for the sake of helping you to understand how to interpret. Now, these two lines, the blue line is the line of resistance. So at some point of time, you can see that the resistance at 5 hertz is this much. And as you increase the frequency, the resistance line remains a flat line. Even your resistance at 20 hertz is the same as the resistance at 5 hertz. So in other words, resistance is frequency independent. No matter what frequency we use, the resistance line, the line of resistance remains a flat line, a straight line. In contrast to that, look at the line of reactance. So the reactance line, it starts from a negative point. So if this is 0.0, it starts from a negative point at 5 hertz. So x5 is a negative value. As you increase the frequency, the reactance becomes less and less negative. It reaches a point of 0 where the reactance is 0, and this point is called as the resonant frequency. And after the resonant frequency, it becomes a positive number. So very interesting. The portion of the reactance before the resistance, before the resonant frequency is your elastance, and after the resonant frequency is your inertance. The triangular portion that we get from 5 hertz to the resonant frequency, this triangular portion is called as area of reactance, or AX. So these are the parameters that you need to understand in oscillometry. For spirometry, we have FEV1, FVC, peak flow, and the FEF 25 to 75. In oscillometry, we have R5, we have R20, the difference between the R5 and the R20. Then you have X5, you have resonant frequency, and then you have the area of reactance. As simple as that. So here are these parameters. The R5, or the resistance at 5 hertz, which is this point here, it tells you the total respiratory resistance. The R20, this point, gives you information about resistance in the large airways. And R5 minus R20 gives you resistance in the small airways. So your resistance values tell you about the 3 different components. So total airway resistance, resistance in the large airways, resistance in the small airways, using these 3 different resistance parameters. Then you have the resonant frequency where the reactance is 0. Then you have the X5, which is the reactance at 5 hertz, which is a negative number. And then this area of reactance, which is a triangular portion. In addition to that, there are 2 more parameters which I would like you to use in your interpretation. X5 during inspiration and X5 during expiration. And I'll show you how useful these are in evaluating patients for their interpretation. X5 inspiratory minus X5 expiratory is called as delta X5. So let's talk about it later. So here is a starter. Here is a graph that I have drawn. I have shown you the resistance values over here, the reactance values over here. The unit is in centimeters water per liter per second. Here is a frequency on the x-axis. So what are the values for R5? So R5 is this point, which is 3 centimeters water per liter per second. Which one is R20? This point is R20, and that is also 3 centimeters water per liter per second. R5 minus R20 is 3 minus 3, which is almost 0. So R5 minus R20 is 0. X5 is this point over here, which is -1. So this is -1 centimeters water per liter per second. And your resonant frequency is at 8 hertz. So your resonant frequency is at 8 hertz. And this is the triangular portion, which are called as area of reactance. This is the fundamental knowledge that you need to have when you want to interpret oscillometry. Now, what do these parameters actually tell you? So I told you about R5, R20, R5 minus R20. I will not repeat it now. X5 gives you three different pieces of information. Small airways obstruction is seen in X5. X5 also represents lung elastance and compliance and lung heterogeneity, as Dr. Lennart mentioned in his presentation. So X5 gives you everything that is happening in the distal portion of the lung, be it the small airways or be it the lung parenchyma. So X5 is giving you that piece of information. Area of reactance is a composite of what is happening again in the distal portion of the lung, both the small airways as well as the lung parenchyma. So X5 and AX are about the distal portion of the lung. AX is a composite, X5 is a single number. Resonant frequency will get impaired during airflow obstruction, but also during lung restriction. And how do you differentiate between the two? I'll mention it in my subsequent slides. Now, this is interesting because I'm going to show you some data over here. X5 inspiratory and X5 expiratory. Now, remember that in patients with obstructive airway disease, they have a difficulty in breathing out. So their X5, the reactance at 5 Hz during expiration is more than during inspiration. And this is classically seen in obstructive airway disease. Exactly the opposite happens in restrictive lung disease, where they have difficulty in breathing in. And therefore, the X5 inspiration is more negative than the X5 expiration. So now you can use your X5 inspiration and X5 expiratory values to understand whether there's obstructive airway disease or whether there is restrictive lung disease. So that's the beauty of this parameter. And I'll show you some examples of this. Now, I did mention about R5 minus R20 as representing small airways, but there is a change that is happening where R5 minus R19 is going to be considered instead of R5 minus R20. And the answer is, why are we using R5 minus R20 and not R5 minus R20? Is because of harmonic distortions. 5 Hz is going to affect 10, 15, 20 because of the harmonics. And therefore, whatever is happening at 5 Hz will get impacted in the 20 Hz also. And therefore, there will be distortions at the 20 Hz and you'll get wrong values. So you use numbers such as prime numbers which cannot be divided. There'll be no harmonics. So R5 is a prime number. 19 is a prime number, and therefore you will get more cleaner signal about the small airways if you use R5 minus R19. Now, although this is the correct parameter to be used for interpretation, for the sake of simplicity, I will use R5 minus R20 for my subsequent slides. Now, here is a classical graph that you get in asthma. This blue dotted line is the line of a normal healthy individual. And this green dotted line is the line of reactance of a normal healthy individual. Now, I told you that in a normal healthy individual, the upper limit of normal for R5 is 4 centimeters water per liter per second. For R20 is 3, and therefore R5 minus R20 should be less than 1. Now, see what has happened in a patient with asthma. The R5 value compared to that of a normal healthy individual has increased. So this is pre-bronchodilator, increase in R5. What has happened to the R20 value compared to that of a normal healthy individual? R20 is also increased. And the R5 minus R20, which is the gap between this point and this point is also increased. So in asthma, you will find increase in R5, you will find increase in R20, and you will find increase in R5 minus R20. After giving a bronchodilator, the R5 value reduces, doesn't come back to normal, or it may come back to normal. The R20 value comes back to normal after giving a bronchodilator. So this is the bronchodilator response that you get in the resistance values in an asthma patient. Now this green dotted line, as I said, is the resonant frequency, so is the line of reactance. This point is the resonant frequency. So see what has happened to the X5 value in an asthmatic patient. Compared to a normal healthy individual, it has become more negative. The resonant frequency in the normal healthy individual is this. This is the resonant frequency in an asthmatic. So you can see that the resonant frequency has shifted to the right. There is a more negative X5 value. The resonant frequency is shifted to the right. And therefore, this triangular portion, which is AX, becomes big in size. After giving a bronchodilator, you can see that the X5 value becomes less negative. From here, pre-bronchodilator to post-bronchodilator, which is here. the resonant frequency shifts from here to the left. So there is a shift in the left after a bronchodilator in resonant frequency, and this triangular portion after a bronchodilator becomes smaller than the pre-bronchodilator value. So this is what you classically get in a patient with asthma. Now see what you get in a patient with COPD. Again, line of resistance in a normal healthy individual. R5 is significantly increased. It increases a lot more than what you find in asthma. R20 value is relatively normal in a patient of COPD because 20 represents large airways. And COPD is a disease that primarily affects only the small airways. So you'll only see an impact on the small airways, which is R5 and the R5 minus R20, significantly bigger over here. R20 is normal, which is large airways. After giving a bronchodilator, you can see some slight bronchodilator response in R5, but no change in R20. Similarly, if you look at the X5 value in a patient of COPD, it becomes very, very negative, more negative. The resonant frequency shifts to the right, and the area of reactance becomes much bigger. If you give a bronchodilator to a patient of COPD, the X5 value becomes less negative, the resonant frequency shifts to the left, and the area of reactance, this triangle becomes smaller. So if you have to evaluate some element of bronchodilator responsiveness in a patient of COPD, reactance parameters will show you a better response than the resistance parameters in patients with COPD. Okay. Now, small airways obstruction is a very important parameter that you get in oscillometry. What is small airways obstruction? Increase in R5. So this is a normal healthy individual. Line of resistance, which is a straight line. Line of reactance. This is X5. This is resonant frequency. And this is the area of reactance, which is a small triangle. This is what you get in a patient with small airways obstruction. R5 value goes high. R20 value is normal. R5 minus R20 becomes a big difference. X5 becomes more negative. Resonant frequency shifts to the right. And the area of reactance becomes big. So these are all the parameters that you get in patients with small airways obstruction. Now, there are some devices that give you values for resistance and reactance, either in centimeters water per liter per second or in kilopascals per liter per second. If you're using an impulse oscillometer, it gives you values in kilopascals per liter per second. If you're using the Tremoflo or if you're using the Indian Antlia device, it will give you values in centimeters water per liter per second. Here is a simple formula for conversion from centimeters water to kilopascals. Okay, as simple as that. Now, just to show you resistance is on this portion and the top portion, reactance starts from the negative value, and these are the different frequencies that I have just mentioned in my earlier slides. Now, this green box tells you what should be, this is the, if your line of resistance is in this green box, it is normal. If your line of reactance is in this blue box, then it is normal. And here is an example. This is the line of resistance. This is the line of reactance. Okay, both of them within the colored box. Now, when you have a line that is higher than the normal, R5 is increased, R20 is also increased, and your R5 minus R20 is 0. This is classically seen in only large airways obstruction. So increase in R5, increase in R20, and R5 minus R20 is normal. This is pure large airways obstruction. Now, when you start getting small airways obstruction, this is the shape of the curve that you get. R5 is increased, R20 is normal, and the R5 minus R20 becomes bigger. This is small airways obstruction. And as the severity of the small airways obstruction increases, such as in asthma or COPD, the lines go higher and higher, and your R5 minus R20, that gap becomes bigger and bigger as your severity increases. This is the line of reactance, normal. So resonant frequency is 10. It should be between 8 to 12. And as these small airways obstruction happens, the line of reactance becomes more negative. I can see X5 has become more negative. Resonant frequency shifts to the right, and the area of reactance becomes big. And as the severity increases, the X5 becomes more negative. Resonant frequency shifts to the right, and the area of reactance becomes bigger. So this is classically what you find in patients with obstructive airway disease. Now, just to give you some examples, R5 is 6 centimeters water per liter per second. R20 is 5. R5 minus R20 is 1. For the sake of your simplicity, I've just put the cutoff values over here, and I've expressed that as percentage change from the cutoff values. So you can see R5 is increased. R20 is also increased. R5 minus R20 is normal. Is there obstruction? And where is it? The obstruction is purely in the large airways. Another example, R5 is increased, R20 is normal, and R5 minus R20 is increased. So normal R20, increase in R5, increase in R5 minus R20. Where is the obstruction? Purely in the small airways. Another example, R5 is increased, R20 is increased, R5 minus R20 is also increased. Everything is increased. Where is the obstruction? The obstruction is both in the large and small airways. So by looking at the R5, R20 and the R5 minus R20, you can categorize your patients into pure large airways obstruction, pure small airways obstruction, or mixed large and small airways obstruction. Okay, simple. Bronchodilator responsiveness. Dr. Lennart highlighted about the importance of looking for bronchodilator responses in patients with asthma or COPD after giving them a bronchodilator. How much bronchodilator response should happen in an oscillometry test? And I think the best study for this is a one that was just published early this year in 2024. This is a study from Sweden, perhaps one of the best studies that I have seen. 23 mild to moderate patients who have good bronchodilator responsiveness. They looked at bronchodilator responsiveness with 3 drugs, SABA alone, SAMA alone, SABA plus SABA, SABA plus SAMA. So the SABA was 400 micrograms and the SAMA was 80 micrograms of ipratropium. And the tool that they used was impulse oscillometry system. And I thought this is absolutely a brilliant study. So let's see what they found. Now, x-axis is the time. So they did the spirometry. Here is FEV1 at multiple time points. And y-axis is the responsiveness of FEV1 in percentage change. So after giving a bronchodilator, focus on this green line over here. So within 10 minutes of 20 minutes, it reaches a peak and then it remains a flat line for about an hour. So what is the bronchodilator responsiveness we got with FEV1? It's just a little over 10%, so I've called it as 12%. And this is exactly the cutoff value that we use. When you look at FEF 25 to 75, the cutoff value that has been reported in the literature is 25%. And here is what they found. So in 10 minutes, it reaches almost the peak. 20 minutes, it reaches the peak. And then it's a straight line. And the responsiveness is just a little about 20. So this cutoff is also correct. Now that they got the correct responsiveness with FEV1 and FEF 25 to 75, what is the equivalent change that they found in the oscillometry indices? So here is the value for R5. You can see that the R5 value reaches a peak by around 10 minutes earlier than the FEV1 and then remains a flat line. And what is the sort of change that they get is around 20%. So I would say that a 20% change in R5 over the baseline is indicative of good bronchodilator responsiveness. For R20, you can see that it's just below 20, so I've called it as 18%. When they look at R5 minus R20, you can see the haphazard lines, but look at the green line over here. The units over here, percentage change is about, so this is 50%, but I can see just a little below 50%. Interestingly, the maximum R5 minus R20 bronchodilator value you get is at 60 minutes. Unlike FEV1, unlike R5, you get it at 10 minutes. Here you get it at 60 minutes. And the percentage change that you get is around 25 to 40%. I think that should be the equivalent for R5 minus R20. For X5, you can see the percentage change. It's around 25%. So if there's a 25% change in X5, we would say that it is good bronchodilator responsiveness. For resonant frequency, you can say that it's 20%. And for area of reactance, it's around 40%. So I would suggest that you should use these cutoff values for good bronchodilator responsiveness in your clinic. Now, this is the only one study which I think is one of the best studies that I've seen. So I'm going to call this as working cutoffs for good bronchodilator reversibility. And I've mentioned the same values that I just showed you earlier. Until there are more studies from different parts of the world that sort of validate this, we should continue to use these cutoff values to say good bronchodilator responsiveness on oscillometry. Now, very quickly, examples of a 3-year-old boy who suffered with asthma, had 3 hospitalizations for probably asthma in the last 1 year. the parents were refusing to accept the diagnosis of asthma because they went and met Dr. Google, and the Google told them that the child may not necessarily have asthma. So they did doctor shopping until they came to our place. Now, this is a report for resistance and reactance. You can see here, this is kilopascals per liter per second. So this is a test that we did on the impulse oscillometry. Blue is pre-bronchodilator, red is post-bronchodilator. I have converted the kilopascals into centimeters water by multiplying it by 10.197. Now look at the shape of these curves, pre-bronchodilator, post-bronchodilator. This is reactance, pre-bronchodilator. So you can see the resonant frequency is almost 35 over here. The X5 is 0.8. I mean, so this is minus 8.15. And look at the bronchodilator response. So the resonant frequency has shifted. The area of reactance has become smaller. Here are the numbers. So if you want to believe in the numbers, here are the numbers. I think anybody who sees this will say that this is a classical case of asthma in a 3-year-old child. Can you imagine doing a spirometry in a 3-year-old child? It's not easy at all. In this child, we did oscillometry, and the parents, we showed them the graph. We showed them the values, and the parents were then convinced that the child has asthma. The child started being put on inhaled corticosteroids, and the child is now perfectly fine. But look at the value of oscillometry in diagnosing pediatric asthma. This is an adult individual, 48-year-old female professional singer, cough with nighttime awakenings, spirometry, pre-bronchodilator, post-bronchodilator. This is the flow volume loop, volume time graph. You can see that the bronchodilator responsiveness is not much, only 7% and 120 ml. Cutoff value is 12% and 200 ml. But look at the changes that we got on oscillometry. Pre-bronchodilator, post-bronchodilator, pre-bronchodilator for reactance and post-bronchodilator for reactance. So here are the values. So what should be the normal R5 for a healthy adult? Should be 4, isn't it? This is 9.6, so it's significantly increased. Reduced to 5.9 after giving a bronchodilator. This is surely more than 20% drop. R20 is also reduced. R5 minus R20, look at this. 3.2, upper limit of normal is 1. So this is a 3-fold increase in the small airways. So this is small airway dysfunction related asthma. After giving a bronchodilator, it reduced by almost 50%. Fits into the bronchodilator responsiveness. Look at X5, minus 3. Cutoff value is minus 1. So 3-fold increase in X5, reduced to almost 50%. Area of reactance, which should have been 4, is now 41. And after giving a bronchodilator, reduces. The resonant frequency is reduced from 30 to 20. Classical case of bronchial asthma, predominantly small airways dysfunction. So spirometry did not pick it up, but oscillometry did. Now, these are two very interesting examples, and this is done on another. This is the Tremoflow device, resistance on the top, reactance at the bottom, pre-bronchodilator, post-bronchodilator, pre-bronchodilator, post-bronchodilator. Here are the values. So I put the cutoff values over here. So R5 is increased, R20 is increased, R5 minus R20 is increased, X5 is 5-fold gone down. Area of reactance is huge. Resonant frequency is shifted to the right. What is the diagnosis? R5 is increased, R20 is increased, R5 minus R20 is almost 4-fold increase. So R20 is not as much increase as R5 and R5 minus R20. So this is classically, this seems to be obstructive airway disease, COPD type, because there is poor bronchodilator responsiveness, as you can see here. Another case over here, resistance is, you can see the resistance is around 5, which is increased. After giving a bronchodilator, there's no change. R5 minus R20, there seems to be some increase over here. But no, but you can see it's almost normal over here. Reactance lines, well, slightly reduced, no change after a bronchodilator, but your resonant frequency is increased to 25. Almost you can see 24 over here. So what is the diagnosis in this case? Now here the X5 inspiratory and X5 expiratory is going to give you the clue. X5 inspiratory is minus 4.8, X5 expiratory is minus 6.5. X5 expiratory is more negative than X5 inspiratory. So this is obstructive airway disease, COPD. Now look at this one. X5 inspiratory is minus 3.3, X5 expiratory is minus 1.28. So the X5 inspiratory is more negative than the X5 expiratory. What is this? So what does this tell you? Restrictive lung disease. So this is COPD and this is interstitial lung disease, classical cases that I've showed you over here. Now, can you tell me what is this? So R5 is increased, poor bronchodilator response. R20 seems to be almost normal, close to normal. And there is an increase in R5 minus R20. X5 has gone significantly down. Resonant frequency is shifted to more than 35. And look at the area of reactance. My God, that's huge. And after giving a bronchodilator, there is absolutely no change. So what is your diagnosis? Let me show you a chest X-ray for that. So post-TB lung disease. This is classical COPD in a patient with post-TB lung fibrosis. Classical, I think you couldn't get a better oscillometry value than this. Interstitial lung disease is a very important new clinical application for oscillometry. And I just showed you one figure earlier. So this is a normal healthy individual resistance, normal healthy individual reactance, and this is the area of reactance. In a patient with interstitial lung disease, resistance does not change much compared to a healthy individual. The X5 becomes a little more negative. Resonant frequency shifts to the right. Area of reactance becomes big because there is pulmonary fibrosis. So the elastance goes off. Becomes a very the lung becomes very elastic, rigid, and therefore you see that change in the small airway component over here. Now there is something called intra-breath oscillometry, which will tell you end expiratory reactance and inspiratory reactance. And you can see that end expiratory is less negative, end inspiratory is more negative. And this shape of the graph, expiratory going more down compared to the, inspiratory going more down compared to expiratory, classically seen in interstitial lung disease. So I believe you can diagnose interstitial lung disease early by looking at the reactance parameters. Look at reactance during inspiration, look at reactance during expiration. And I believe that follow-up of these patients, if you started them on an antifibrotic drug, I think X5 is going to be a very good parameter to tell you whether the patient is getting better or not. Last couple of slides, and just to highlight some of the importance of oscillometry in lung transplant, the message that I wanted to convey is lung transplant patients have a risk of developing lung rejection, and oscillometry can pick that up 3 days in advance compared to even what other tools such as spirometry does. So this is a very old study that was published in 2010. And there's some recent studies have shown that lung transplant rejection could be bronchiolitis obliterans, could be restrictive allograft syndrome. This is obstructive, this is restrictive. And oscillometry can actually give you that distinction. This is a rejection which is obstructive, and this is a rejection which is restrictive, and so simple to perform in these patients. So what are the distinct advantages of lung oscillometry? Easy to perform, needs normal tidal breathing, not like spirometry. Does not need predicted values. Height seems to be the only parameter that determines the values of oscillometry indices. Cutoff values to help differentiate between normal and abnormal, and provides additional information about lungs than what spirometry does. So it tells you about elastance, capacitance, which spirometry does not. Spirometry gives you lung volumes, gives you lung flows. It doesn't give you the elastance properties of the lung. What do I see as the future of oscillometry? And I think these are very exciting times. Oscillometry will be immensely beneficial in the diagnosis of SAD asthma. 50% of the asthmatics that we see in our clinics have SAD asthma, predominant small airways dysfunction. Now, diagnosing SAD asthma and treating them with ultrafine inhaled corticosteroids is going to be the future of treating these patients. But how do you diagnose SAD asthma? Oscillometry. Diagnosis of early COPD or pre-COPD, because small airways are affected. Spirometry is not very sensitive to pick up small airways obstruction. Oscillometry is. So pre-COPD cases can be picked up on oscillometry. Diagnosis and response to treatment of interstitial lung disease. I've just shown you some slides with respect to that. Post-lung transplant management, I think oscillometry is going to be the future. And then finally, there is a tool that is in the developmental stage. It's a monofrequency oscillometry. Just like the peak flow meter, this is going to be like a single frequency oscillometry, 5 Hertz. And you can use this in the clinic for screening purposes. So very, very exciting times ahead for oscillometry. I would stop over here, and I hope I've not taken too much of time, but I hope you all have understood the secrets of interpreting oscillometry. Thank you so much. Dr. Salil Bendre, all yours.
Yeah, thank you, sir. It's really always, as I mentioned in the beginning, a pleasure to listen to your talk. You make it sound so simple, make it very easy to understand. And though it's a branch which we are seeing in the recent years, but every time we learn a lot. And many questions were getting bombarded into the chat box. And through your talk, almost you have been able to, answer many of those doubts about restriction and obstruction. So thankful to you for that wonderful talk. I will proceed. Yeah, I will proceed to Dr. Rajesh Swarnakar now. Again, he is a very well-known pulmonologist, very active in every program and every academic initiative. He is presently the president of the Southeast Asian Academy of Sleep Medicine, National Treasurer, Indian Chest Society, a director and chief pulmonary consultant at the Getwell Hospital and Research Institute. Again, has many papers to it credit, and he's been the medical director of Center of Excellence in Clinical Research. This is a research, consulting, and site facilitating organization in Nagpur. And of course, is a member of the editorial board of Lung India. So without further delay, I would request Dr. Rajesh to please present his cases so that we can get a more easier understanding of this test, the oscillometry. So Dr. Rajesh, over to you. Aditi, you would be putting on the recording?
Yes, sir, we are playing the recording. Just a moment. I'm just sharing the screen.
Yeah.
After the talks, hello everybody, and after the talks of two stalwarts, Dr. Leonard and Dr. Sadhvi, who have now set the stage for further discussion on oscillometry, and it is seen that everybody wants to interpret oscillometry and to learn how to do it. So my job today is to bring to you some very simple case illustration for actually the beginners who have started doing oscillometry, to understand how you can imply this oscillometry, how you can do oscillometry in your daily practice. So let me share my presentation, and here we go. So some cases that I have selected from my own actually daily practice, and before we see the cases, it's often that we get asked that how to really begin doing oscillometry in a daily practice. So which are the cases that would actually benefit from doing oscillometry? So very simple, you can, if you've got a periodic practice, then very young patients, the old patients, the physically challenged patients, and others who are not able to perform the forced expiratory maneuver that is required to get good result in spirometry. These are the patients, and these are about 20% of the patient. Established that about 20% of patients will not be able to do spirometry. So these are your straight cases in which you can try and do oscillometry in those patients. Then you know that spirometry has got 29 contraindications, while there are none for doing oscillometry. So in patients on whom there is this contraindication of doing it, like recent cardiac events, recent pneumothorax, thromboembolism, you can do spirometry because it doesn't cause any stress to any of your system, and in fact it is said that anyone who can breathe can do the oscillometry. Another is if you have a patient and if you are having the history and suspecting that he may be having obstructing airway disease, but you find that, or despite you have done actually good spirometry, it is coming normal. So it is basically a worthwhile exercise to do oscillometry in these patients and to see if there is an obstruction as per the history that you have elucidated. Because within a spirometry, if you do actually, oscillometry is much more sensitive than spirometry in detecting these cases. Another cases that you would see subsequently is when you do a spirometry, there is obstruction, but we don't know where the obstruction is there, whether it is central obstruction or if there is a peripheral small airway disease. So oscillometry is the tool that will also tell you where is the obstruction, whether it is central or peripheral, and this has got therapeutic outcomes, as you would see in my cases. And it's been said that oscillometry is also now actually recognized as a tool to detect early COPD. There are studies going on to also have this fact established, and there are papers now. And another indication where actually spirometry has almost gone out of use or oscillometry has taken over is to actually detect early lung transplant rejection. You know that these patients are very fragile patients, have to be followed up, and we do surveillance bronchoscopy also periodically to see the early rejection. And here we are seeing that the oscillometry has come very handy. Now, when you start doing oscillometry and you've got both the tools, as I'm doing it since last 4 or 5 years, initially I do oscillometry and spirometry both in all new patients. And when you do this, always do oscillometry first and then the spirometry. So these are the cases that would tell you this is a 90-year-old Amma who had refused to do the PFT. Every time she used to come, she used to say, no, please don't subject me to oscillometry. She had asthma. And now I'm actually monitoring her through oscillometry only, and she's happy to do it. Same is the case with these patients. They are young patients, as young as 2-year-old, and they are happy to do this, and you don't get much time, and you can do it quickly, in fact. So these are the early patients that you can do. This is a patient who is actually physically challenged, is a patient of Duchenne atrophy, was not able to do his daily activities through his hands and through legs, and this patient is able to do oscillometry very easily. So these are the initial patients that you can basically deploy oscillometry for treating various obstructive disease or conditions. So let's begin with a very simple case. As I said, that spirometry vis-a-vis oscillometry is not at all very sensitive tool. So you get cases in which there is normal spirometry and abnormal oscillometry. So this is a patient who had clear history of obstructive disease, had wheeze, history of wheeze, has also nasal allergy, nasal block, all those symptoms of allergic bronchial asthma. But this PFT came actually normal and the spirometry came normal. But when we did the oscillometry, you could see that there is an obstruction and there is some sort of reversibility is there. So this is obstructive disease which can be missed by actually spirometry, and if you've got history, you can check doing oscillometry and see, and again revisit the diagnosis. Another case, this is an excellent demonstration of asthma's reversibility, as we know that oscillometry is more sensitive than spirometry to show reversibility or even bronchoprovocation in the same dose which is used for spirometry. So this case illustrates that there is obstruction. This is a case of asthma, and we do the reversibility test after bronchodilation. See actually reversibility in this case when we do spirometry, and then when we do the oscillometry, see there is a robust change of betterment in AX and all those parameters, R5 minus 20, showing that this is a case of asthma, and reversibility is quite robust. And the same dose of 4 puffs of salbutamol, it was given to both in like both the cases of spirometry and oscillometry, but see the change. This is another case where this is a perfect example of how you can show the reversibility in oscillometry. So the curves would come at actual closure. So this is pre-bronchodilation, this is post, and it is showing the change for the better in AX and R5 minus 20. And by looking at the graph itself, you can see that this is a case of reversible obstructive disease and of maybe a case of asthma. Another similar case in which we see that spirometry is normal, all the values are in green, but you can see a little bit of obstruction when you pick the oscillometry. This is the same patient, and we did the oscillometry first and then spirometry, and found that serote became normal, but oscillometry is showing the obstruction and some sort of reversibility, maybe partial reversibility, a case of some obstructive disease, actually definitely. Another case which illustrates the same finding, abnormal oscillometry but normal. This is another case. You see a very mild obstruction, but see that this is a case in which there is the reactance has really been gone down, and this is maybe a case of obstructive disease. I think probably COPD or something, because reactance is affected much more, and you can see the values which are in red. This case is a very interesting illustration that spirometry shows obstructive disease with significant reversibility, which is suggestive of asthma. And this case I have taken to show that when you do spirometry, we don't know where the obstruction is, but here you can see that oscillometry clearly shows that it is actually a predominant central airway obstruction. Look at the curves. This is the spirometry, and this is the oscillometry, which shows actually resistance is affected much more. So R20 is affected much more. So there's central. So you see the curves. This is almost parallel to the normal curve, and after bronchodilation, the pre-post values, see the only upper of resistance values have changed, while the value below are not much affected. So I think this is a case of central airway obstruction. Similarly, what you can see in some cases is that this is a predominant small airway obstruction where R20 is normal, while R5 minus 20 and X, which are the parameters to know the small airway functions, are affected. Now this has got also treatment implications, as I had said earlier, in the sense that if this patient comes to you and is not improving with, I think, with the normal inhalers, you have checked also their adherence and also their basically how they do this inhalers, and also technique is right. So in this patient, there is a good case of employing the ultrafine particle inhaler maybe for 3 to 4 months, and then again see if they improve. So because this is a patient who has got a predominant small airway obstruction, and by giving the treatment, by just giving the correct treatment by ultrafine particle inhalers, maybe this patient actually can improve. So this has got treatment outcomes as to what treatment you can deploy, and oscillometry actually assists in this very well to know the level of obstruction, whether it is central or peripheral. So of course this is a case of both peripheral and central obstruction, which would be much more in cases of COPD. So we come to COPD. So this is a trumpet sign, which is there in both when obstruction is both central and also peripheral. More so reactance curve has gone down. So probably smoker or COPD patients, or maybe a patient of asthma, but not much of reversibility. So maybe more cases of COPD. This was his spirometry. This was her spirometry. And as I said, that oscillometry is very sensitive for detecting early COPD and shows abnormality much more often than a spirometry. The spirometry is normal in this patient, but when you do oscillometry, you see this reactance curve or X5 is deflected downwards. And this is very typical of a COPD when you observe the curves. And when you see these oscillographs often and on a daily basis, you would pick up these curves and their abnormality just like that without seeing the absolute values which are there, and same thing we used to do for the also spirometry. So this X5 deflection is very typical of COPD, as we can see. And this patient, we also did a CT scan because his spirometry was normal, and then we did HRCT chest, and it indeed showed some changes of smoking, in fact early smoking related interstitial fibrosis and also mild respiratory bronchiolitis. And we confirmed this because we got facility of this also lung also density analysis software from 𝐒𝐵io, and this also showed actually presence of low density areas with bilateral low predominance correlating with the HRCT finding, and also oscillometry of non-destructive centralized emphysematous changes. So this is what oscillometry can do. It is an excellent example to correlate the findings. As I said, early COPD, so you see the deflection in the X5, this curve. So you should look at this. This is very typical of COPD, that resistance at X5 is affected quite early, and hence we can detect this. See again, this is another example of early COPD. See the deflection of X5 downwards, and of course, as against asthma, you will see the reversity in COPD, which is partial, so it won't be that much. So we got some cutoff values which are there for reversity for oscillometry, and in this case, it is not that much. So this is a partiality in a patient who has got partiality or obstructive AV disease. Now, a lot of questions asked about whether oscillometry can also detect actually restrictive pattern or more so in ILD patients. So initially we didn't have much of data, but now data has come into the literature where we are actually detecting this. And simple, if we have got history of the patient, is not a smoker, has got no history of asthma or any obstructive disease, and you see a curve which has got this normal resistance and abnormal reactance, as this is the case. This is the patient, and this is patient's spirometry, which clearly detects it. It is a restrictive curve, and you see this oscillometry that resistance is normal. R5, R20, they are all in green, but AX and X5 are affected. So in a patient in whom you have got a good history, if you see this case, then maybe you can actually suspect interstitial lung disease, and actually and this is a restrictive pattern. Going further, now we have got now intra-breath analysis, and we have got X5 also values. So you tease out into the breath into inspiration and expiration, and you can have the parameters of oscillometry being measured in these two phases of respiration. And by knowing the difference between these, we can detect. So we employ X5 values in inspiration and expiration, and in case of interstitial lung disease, or when you have a restrictive pattern and you see that X5 inspiratory is more than X5 expiratory, then this may be a case of interstitial lung disease. And now also we're also generating further data, and studies are coming, and maybe this would be established as the parameter to also detect interstitial lung disease. And to conclude, as I say, I had opportunity to do oscillometry also in patients who had undergone lung transplant, and this is a big article which came in the Blue Journal in 2020, which said that airway oscillometry detects barometric silent episodes of acute cellular rejection, which are quite early, and you can diagnose actually lung transplant rejection by actually knowing this ACR quite early. And this article concluded that our observation and the ease of conducting oscillometry provide a solid and compelling rationale for incorporating oscillometry as an adjunct to spirometry for patients monitoring after lung transplant, and in particular to those patients or in centers that do not perform routine surveillance bronchoscopy with transbronchial biopsy, which is an invasive procedure. So oscillometry can facilitate identification of acute cell rejection, and hence a response to treatment can actually save that lung, and it could ultimately help stratify patients' risk with respect to the clinical outcomes. And this was the case that we got of lung transplant, and the values to see it is AX and X5. So these values are in fact important when you have this lung transplant patient and see that it's being affected. This patient had indeed a problem. We did a surveillance bronchoscopy, and there was basically a problem in this patient. There was obstruction, and we could detect, and then we could basically also transfer this information to the lung transplant physician, and then hopefully we can take corrective steps. So these are some of the case histories or case which I have picked up from my own practice, and this is a beginner's thing, and I would suggest all of you to, and then when you got oscillometry in your own clinic, hospital, you should try to do both, actually both, I mean together. Maybe you can, maybe when you're learning, you can also subsidize your oscillometry cost. That's what I did. I used to do oscillometry free of cost first, actually before doing my routine spirometries, and I used to correlate the findings, and then you learn very fast. And I would say that basically you should do both, and they should be done in conjunction, and you can get more and more values. It adds to the value if you do both the thing, both oscillometry and spirometry together. As information you get is immense, and as you learn, you would know that how it can help in your clinical practice to also manage your patients. Thank you for your patient listening.
Thank you, Dr. Rajesh. All those cases have really been helpful. You know, the cases, the graphs which you showed. I think real life scenarios are very important for any of us to understand technology. So I'm getting lots and lots of questions, and I'll just introduce two of the panelists who are going to be joining us now. We have with us Professor Dr. Ravi Doshi. He is the head of Department of Respiratory Medicine at Kokilabhen Dhirubhai Ambani Hospital at Indore, MP. He was initially as the head of department at SAMC PGI Indore, MP. He is awarded with many awards: the IMA Best Teacher Award 2020, the Best Young Physician Award, Padma Shri Dr. S.M. Mukherjee Award, and has many publications in Index Journal. Always very active, and also well known for his YouTube exploits of creating health awareness videos and so on and so forth. So welcome, Dr. Ravi. And we have with us young dynamic pulmonologist, Dr. Mandeep Kaur Sodhi. She is a MD Pulmonary Medicine, DNB Pulmonary Medicine, and presently the Assistant Professor, Department of Pulmonary Critical Care and Sleep Medicine at the Government Medical College Hospital, Sector 32, Chandigarh. Member of many associations, international, national, very active in academics, and of course she will be sharing her experiences with the oscillometer. So without further delay, we have got some amount of questions which I need to definitely ask our panelists. So Ravi, just to open from your end, you know, before we were planning to do this panel discussion, Rajesh is live now. He had sent me a text message 3 days back. Never call it iOS. You should call it oscillometry. It's like using a Xerox as a word for a copier. So I'm just going to ask you a simple question. We hear of FOT, we hear of iOS. So what exactly are the differences, and what is the technical difference in this?
So basically, FOT was the initial technique whereby sound waves were used at fixed frequencies, particularly like let's say 5, 10, and 30. and they were transmitted, and the properties were measured. Whereas in impulse oscillometry, a whole range of frequencies is given, multiple impulses are given, and the properties are measured at all the frequencies in the lung.
Okay.
No. Sorry.
Dr. Leonard, yes, please.
Yeah, no, this is a source for misunderstanding. The iOS device delivers or tries to deliver square waves. Now, if you know anything about square waves, they are made up of an almost infinite number of frequencies and a lot of high frequencies. Otherwise, you wouldn't get the sharp, quick rise in the initial of the pulse. So the way they do it is that every 0.2 seconds they deliver such a pulse, one in, one out, one in, one out. So the basic frequency by which the speaker, because it's a speaker membrane being shifted back and forth, is every 0.2 seconds, which is 5 hertz, right? So when you do this with a speaker membrane, you will also generate the harmonics of 5 hertz. And as Sandeep Selvey discussed before, you will then have this harmonic interference at all the multiple frequencies of 5. So 10, 15, 20, 25, and so on and so forth. The power spectrum is not controlled. The only thing they control is really that the speaker flips back and forth. So they have no control over the power of the signal going in. It's probably a lot stronger than any of the other devices, be that Antilia, Resmon, or Tremoflow, because it's not controlled. They don't have any feedback. So what sets that apart from the multi-frequency oscillometry that we're using these days, on which all the modern devices are based on, is that we do have a much higher precision control on the flow, pressure, and volume. We produce continuous sine waves, meaning that we're measuring continuously over the whole time, not only when the pulse appears. We use prime numbers. Prime numbers are important because then you avoid all those harmonic interferences. And so you'll have a much higher quality signal. The frequencies cover the range of interest. We don't have any unnecessary frequencies going high or below. So we don't create a lot of noise using the well-defined sine waves. Another thing, we can also control the amplitudes for all the individual frequencies. We produce the highest power at the lowest frequency, 5 hertz in most cases, right? Then you scale that roughly inversely to the frequency content. Sort of a bit technical here, but the question was such, right? And that you do that so that you retain the same power at a frequency of, say, 19 as the frequency of 5 hertz. And you do that by scale it inversely to the frequency. So all of this just generates a much higher quality signal going in. It also allows for a much better analysis because you know exactly what you put in, you know exactly what should come back out. So if something else comes out, you know it wasn't my signal. You can eliminate that from the analysis. So I think all of these things just generate a much better quality device. That being said, iOS was a wonderful invention back in the late 1980s when it was invented. And you have to remember that they didn't have the computers we have today, so they were limited to what they could do. So a pulse would sort of limit the number of data points they had to analyze. Because now you have space between, you have 2.2 seconds space between each and every pulse, which allowed the computers at the time to actually crunch the numbers. Today, we can actually do the same thing with a continuous sine wave. So yeah, we do have a much higher quality these days. That's essentially what it boils down to.
Yeah. Thank you so much for that explanation, Dr. Selvey, sir. That There is a question which is coming up about the in pre-operative, because we generally apply spirometry even in surgeries for fitness. So how do we use that in terms of oscillometry?
Good question. I'm not aware of any good study that has evaluated the role of oscillometry for pre-operative fitness. Now, my logic tells me that whenever you want to operate a patient, maybe it's a thoracic surgery or an abdominal surgery, lung volumes will probably be more important and relevant than your resistance and your reactance that we find on oscillometry. So I would rather use spirometry for a pre-operative fitness or pre-operative evaluation. Oscillometry, there's no study as of now. So until we get that, until we develop that science, I don't think we should recommend that.
Thank you. So that clarification was important, because almost 5-6 questions had come regarding how do we evaluate for operation, surgery, pre-operative. So Mandeep, we have already had a couple of talks, but again, there are a few clarifications needed from our audience, that if I have to differentiate asthma and COPD based on an oscillometry, what parameters and how should I pick up small pointers to understand? So just make it a very simple explanation for them. Maybe a summary of whatever the slides were shown, asthma and COPD in terms of oscillometry.
Okay, good evening, everyone. So basically, as very beautifully explained by Dr. Salvi, we ideally both are obstructive airway diseases, but basically in asthma, there is a mixture. To start with, in a pure asthma phenotype, it is a large airway obstruction. So the resistance at all the frequencies is going to increase. We will see that there will be an increase in the R5. There will be an increase also in the R20 because the central airways are involved, earlier. Also, the difference in R5, R20 would be there, but that would be not very great. Whereas in COPD, what we see is that since the small airways are predominantly involved, so R20, first of all, would be in the normal range, very close to normal. R5 would increase, and the difference between the two, that is R5 and R20, is going to be a very big value. Also, in COPD, the reactance is one parameter that shifts more compared to resistance. So if we compare with asthma, the parameter that dominates in COPD is reactance. Also, when we do the post-bronchodilator studies, the asthma patients will show a very good reversibility. R20, that is the large airway obstruction, almost disappears. It comes down to the pre-bronchodilator levels. R5 decreases as well. Whereas in COPD, the levels would decrease. That is a kind of a partial reversibility. So that is when I'm talking about, a purely asthma phenotype, not a mixed or not something with airway remodeling, sir.
Absolutely. So fine, at least that gives a rough idea, because the ones who are just starting off doing an oscillometry, they will be more easier to understand this concept. So coming, Ravi, back to you. Also, we have got certain questions which are being asked on what's the role of oscillometry in upper and the central airway obstruction, and how does it help us? Is it anything on that? Any pointers you want to put on that?
Basically, if in upper airway obstruction, there is a rise in all the resistance parameters, whereas in central airway obstruction, the R5, R20 difference will be maintained. Only the R5 and R20 will be raised.
Okay. Dr. Leonard, since you have done a lot of work on school-going children, we are seeing that almost a good number of people who have developed asthma later actually start off with allergic rhinitis. And that is also a very common symptom in the school-going age group. So do you have any such data where children with allergic rhinitis were actually screened by oscillometry, and where it was found if they were not yet diagnosed to have asthma, but the oscillometry picked up the obstructive airway disease in them?
I'm not sure if there's this study in children particularly, but there are studies in adults at least showing that allergic rhinitis tend to bleed over into the lungs as well. Now, I'm not sure how it is in India, but in a lot of countries, there's a strong separation between ear, throat, nose doctors and lung doctors, right? So the people looking at the head part sort of the airways, they don't really think much about the lungs. I think if we could put oscillometry devices in their hands and ask them to check the lungs just randomly, you probably would pick up a lot of people who do actually, unbeknownst to themselves, issues with the lung health. We have a study. I know of a study in California in young children starting from age 2 up to age 7. They were admitted into the study by their GPs, presuming that they were well controlled, all based on either spirometry in the cases kids could do spirometry, or just by you know, the usual you know, auscultation of the kid. And then they were tested with oscillometry in the study, and they found that somewhere between 50 and 60% of the kids presumed by the GPs being well controlled were actually not well controlled. They still had strong signs of small airways disease. So, you know, I think children is really an underserved population in airways diseases.
So thank you for that. Mandeep, I wanted to ask you that, you know, now oscillometry is helping us to identify small airway disease, and sir also mentioned about small airway disease asthma. In your practice, have you actually found that there is an increase, you're detecting much more? And that is one question. Secondly, if you're detecting and you start them with the usage of extra fine particulate, when is the good time to repeat oscillometry?
Okay, so basically, you know, in our OPDs, we many times have patients who have got the symptoms. There is MMRC, dyspnea grade 2, they may be smokers, but the spirometry when done, that comes out to be normal. So those are the cases where we have found that, you know, impulse oscillometry can definitely help to, you know, pick up the early lung changes, the small airway obstruction much more earlier than spirometry, which is also a positive reinforcing effect for the patient to stop smoking, because it serves as a danger sign for that patient. Also, once the detection is done, there is very good role of the targeted therapy that is being talked about these days. We have the Nivioli inhaler and the extra fine formulations that we say. And I think there are no clear-cut rules, but we usually like to do it after 12 weeks or like 3 months of treatment, you know.
Yeah. Correct. I think that would be a good time to clinically assess plus see the change in the physiological obstruction which comes in. Coming to Ravi, there's a question in the chat box which talks about, I think someone has messaged me that there's a 7-month-old pregnant lady and we are suspecting she has got obstructive airway disease. Can we go ahead with the oscillometry in pregnancy?
Well, if the clinical need is there, sir, I have not been able to find out any contraindication to that. I think if needed, it can be gone. We can go ahead with IS in such a situation, sir.
So any contraindication for oscillometry?
Yeah, Salil, as I was saying, in fact, there is no contraindication to oscillometry, and all those contraindications that exist for spirometry are not there for that, because we are also using oscillometry in our ICU patients and also patients who are also on basically ventilators. Right. So then I think anyone who can breathe, as I said, I think can do oscillometry, and there is no absolute contraindication. And of course, pregnant ladies are one of a very good indication in which you can deploy oscillometry instead of spirometry. And then of course, if she's just 6 or 7 months pregnant, you know, so that is I think a better tool, and we should do that. We should deploy oscillometry.
So Rajesh, since you are in the firing line, I want to ask you a question now. If someone is asking which one to buy, would you tell them about a particular?
So there is a lot of conflict of interest here with us, in fact, here. So that question should be best avoided. But because, you know, we've been using our various oscillometers, but then of course, basically about 10 years back, we just had one only, and then you had also mentioned IS was master screen that was made by Eger, and now it is outdated, in fact. So they are not even servicing their oscillometries now. But I think lately, in last about 10 years, and I think India is quite lucky enough to have, I think, 3 or 4 devices. And the range is quite good. So basically you can get from 3 lakhs to about 10 lakhs. So it depends what is your practice. In fact, whether you're also doing periodic practice and whether you are doing, whether you need a portable device, how much portability you need, and then you should look at the cost of it, and then also recovery of it. In fact, in initial practice, if you got a very good practice, then you can then go for a higher version, in fact, and which is good one. And then you should also look at the cost of the recurrence cost, in fact, for the load test, how much is the expiry, and I think all those things. So all this thing has to be done. But then anyone which is available are quite good, in fact, and just to begin with, I think you can take anyone and at least begin, and then after you can go for a higher version once you know that this how it works.
Yeah. So that's absolutely well answered, politically correct and generally correct. So it's a good answer. You know, the Dr. Tridib, he's a senior pulmonologist. He just made a comment that we are talking so much of small airway disease, but how is the pharma company? Only one of them has got actually a ultrafine particulate, or that's a real surprise, because we need something to really treat these small airway diseases with a good deposition at that instance. So coming to last couple of questions, because we are already overshot the time, and I think ICS, Dr. Salvi sir, you need to arrange part 2 in the next month. But before we end up, last couple of questions. One is to Dr. Mandeep. See, again, there are a few doubts about, in spirometry, we know mild, moderate, severe. We always try to understand that. How do we go ahead about that in oscillometry for asthma, COPD? How do we do that?
So as far as I'm aware, as of now, there are no clear-cut values to distinguish mild, moderate, severe in case of obstructive or restrictive diseases. Although some machines have got these machine learning algorithms which are giving these stages, which are automated. But like if we just see the indexes as such, so in asthma, what we see is that there was one study which showed that except for the central airway resistance, R20, which did not change across all severities of asthma, the other parameters like, R5, R20, X5 and AX, they subsequently, increased and became more abnormal as the disease progressed. Similarly, for COPD, that we have data from the ECLIPSE cohort. Now that showed that as the disease progressed from gold stage 2 to 4, the greatest change that they saw was in the area of reactance, because that is the part that is the peripheral airway and the lung, that is compliance, which is more affected. So the change was as good as 136%. And similarly in ILD, I think X5 values would give a better parameter of the progression of the disease. But yes, there are no clear-cut values that I am aware of till now.
Yeah. So
I think there's been studies which have correlated AX values with gold guidelines of COPD. So there was a study, and as Leonard would also say that AX 10 and then up 10 to 20, 20 to 40. So they've got this correlation with this gold, and also stage 1, 2, 3 and 4, but not as much. So as I said, you have to basically also do your PFT test and then also your basic spirometry. I mean, you can't do everything with oscillometry now. And after when you do together, you can get more information than just doing one thing alone.
Right. So possibly that another 3-4 people who have put, why isn't it in the guidelines? Why is it not in the guidelines? I think
no.
Yeah.
No,
I think we should ask Salvi. Dr. Salvi should answer this question. He is in gold and GINA guidelines as well. So I think he would be telling us the inside story that why we are not generating so much of data. And for you also know that now for papers have increased. Why it is there is not just a single line of oscillometry in either of the guidelines.
I think what we I will let you speak. I think what we are doing here today, or actually what the Indian Chest Society is doing here today, is fantastic, because all of these things, changes in guidelines, recommendations from authorities, acceptance for reimbursement, and all of those things has to come from the ground up. This is nothing that industry or a few KOLs can sort of impose on insurance companies or on governments to accept. This is something that has to come from the ground up. And I think getting the support of the Indian Chest Society for a good cause is one example of this, which I think is one of the reasons that India is actually one of the places where oscillometry is being accepted and used a lot in the clinical setting. Whereas if you go to the more traditional areas of Europe and North America. It's very much a research tool. And so we see, it depends on how you start the whole process, right? And when it comes to cutoffs, yes, I think we will eventually end up there. And I know there are studies in asthma in children going on here in Montreal, looking at that. We had that sort of feeble attempt that I and Dr. Dandurand did a few years ago with COPD. That was sort of an example of what could perhaps be done. Nobody has picked up that thread yet, but I think it will come.
Yeah,
Sorry.
So Dr. Rajesh, to answer that, it will get into the guidelines eventually. I did speak to the chairman of GINA and said, SAD asthma is becoming such an important phenotype in clinical practice. Why is there no attempt to mention something about it in the GINA document? So the answer that she gave was very simple. She said, Sandeep, yes, SAD asthma is becoming very popular and very, very important. But as of now, there is no good treatment. At least there are no randomized controlled trials to show that SAD asthma can be treated effectively with a particular drug. So until the therapeutic evidence is seen clinically through good randomized controlled trials, we cannot include it in the GINA just as a very nice thing for the future, but it has to have practical application. And the same thing for COPD as well. Until we have ultrafine particles that can target the small airways, and the studies show that it actually creates benefit, it'll take time for it to get into the guidelines. But I'm sure eventually it will. I think oscillometry is becoming very popular in most parts of the world now. So it's just a matter of time.
Yeah. So last word on it, Ravi. One last question, then we wind up. If you are given a choice, you see a patient in your OPD, you have got both the machines and hand, a spirometry and oscillometry. You see the patient and you say, no, this patient has to undergo oscillometry only, not a spirometry. So which would be those 1, 2, 3, 4 who are very much characteristically should be are indicated for oscillometry, not for a spirometry?
Well, sir, patients whom I feel will not be able to follow the protocol of spirometry, like children, elderly, who will be finding it difficult to perform the conventional spirometry, I would prefer an iOS. Definitely in conditions where I feel there is a suspicion that it is too early, like maybe conditions like pre-COPD, or maybe a lung transplant scenario where we are suspecting a potential rejection. In such sort of a patient, I would like to go in for a iOS, definitely. And suppose we have an infant or an ICU patient like Rajesh Swankar told. In such conditions, spirometry is out of the question, but iOS would be a definite indication.
Wonderful. So I think we have covered an exhaustive, topic, though many things yet to be answered. I have got another 12 questions, which I told Dr. Sarvi, next webinar we can take them. But I heartily thank all the wonderful speakers, Dr. Leonard, Dr. Sarvi, Dr. Rajesh, Dr. Ravi, Dr. Mandeep, everyone. And of course, Indian Chess Society for getting this initiative on. Thankful all the listeners who have logged in throughout the program, though it has been much more than the timing which was expected. And of course, Lupin for being there and helping us out with the technological backup. So with that, we thank you all. And I thank all the wonderful esteemed panelists and speakers once again. Good night, sir. Thank you so much.
Thank you, Salil, for a wonderful moderation. Thank you. Thank you, Salil.
Everyone.
Bye-bye.
Thank you, everyone. Good night. Thank you.
Bye. Good
Thank
night.
you, everyone.